Hello everyone and welcome to the first T. I hope you're all excited to be here. My name is Joe Barnes and I'm one of the head instructors for the program. Just like any other EMT course that you've ever had, there's going to be some introductions and some covering of topics you've covered in the past, and that's no exception here. So we're going to jump into that. I would encourage you to take notes. It's always important in new educational endeavors that you understand, and the best way to understand is by writing things down. Following writing things down, it's always important to go back, review your notes, trim them down, make a good outline format, something that you can study later and pick up on. So let's jump right on. The instructors of the program, our course coordinator is Mrs. Shirley Schreiber. She's an EMT paramedic, 30 plus years experience, 911 education, you name it. She's been all over the board, as well as even owning an ambulance company. My name is Joe Barnes. I'm the Chief of Education for the program. You will hear a lot from me. I will be the one grading a lot of the assignments as well as making comments to you. Hopefully we have a great relationship. Next instructor is David Garcia. Again, somebody with decades of experience. He's got a degree in paramedic science, and he's a great instructor. He works in 911 in a very busy system. As well, he is a former owner of an ambulance company, so he can give a lot of insight on what you can expect from different companies and different places that you go in EMS. Excuse me. So this is how the class works. These online presentations, you'll notice on the screen there is a place to ask questions. So that is always monitored. If you're in the class and you have a question, say we're talking about the lungs, and you want to know, for example, why are there 2 lobes on the left and 3 lobes on the right, you can type your question in and ask it, and our instructor will be able to see your question and answer the question, and everyone else will also get to see you and answer your question as far as that goes. So we have the online presentations. There are also face-to-face sessions in different locations around the state that we have. Most of the classes are going to be primarily in San Antonio area, Pleasanton, Texas area, Houston, Texas area, but there's other areas that we will be having classes. We have what's called a capstone event, and for EMTs, it's one weekend that starts on a Friday midday and stretches through Sunday evening. And for advanced EMT, there's 2 weekends like that. And the way the capstone event works is you will come in to the area predetermined, all that information will be sent to you, and you will for 3 days do skills training and or testing in the event that that's what's going on. Some of the classes will not be set up for capstone. I don't believe this advanced class is set up for capstone. In other words, you will be meeting weekly, or at least being given assignments weekly for skills training and testing. Just like your EMT, there was a field internship. That's a fancy way to say riding in an ambulance and experiencing what we do in the field. Our big component of that is not just learning, but professionalism. We pride ourselves on presenting ourselves professionally, and these people talk to our instructors routinely. And again, you got to be professional. If you're not professional, that's the fastest way to be removed from the program outside of academic dishonesty. Next, we have the hospital internships. These are programs where hospitals allow us to come into their facilities. We get to train alongside professionals that have been licensed and in the field. It's a great opportunity. And once again, professionalism is our primary goal in those situations. We do have exams and quizzes. Primarily every class you will have at least one quiz. You have as many as 3 exams, not including your final exam. And since I mentioned final, I'll go into the next point, which is the renote project that is due before the final exam. When I was in law school at St. Mary's University in San Antonio, one of the big components was how you took notes. And the professors impressed upon the law students that if you're going to be successful in retaining information, you have to be a master at note taking. And some of you may think that you're great at it, and some of you may be. But I want to give you a little bit of a head start, and this Renote project is a big part of that. When you take notes, generally it's in a fast-paced situation. You're writing stuff down as it comes to you, as you hear it, and you think that's important. You might even be color coding. But usually 3 to 4 days later, your notes look like chicken scratch for the most part. You might remember the things that stuck out at you, the funny stuff, that kind of thing. But before then and after the class, you're just kind of in a lost position. So what the Renote project is, each day when you take your notes, you're encouraged after class to redo your notes, reformat your notes, trim them down, cut out the fat, so to speak. In other words, if you wrote down 15 things on how the kidneys process fluids, you might want to put that in a better bullet point position. You might want to remove some of the wordiness in your definitions, or you might want to add some words to your definitions and make it clean. As you go through the class, you'll be doing this multiple times and trimming that note down till you get from maybe 200 or 300 pages of notes down to 15 or 20 pages of condensed, clean, solid notes that can make sense to study for a final exam and ultimately your national registry. We do have writing projects in this course. For most of the colleges around the country, if you're already certified as an EMT or an advanced EMT or paramedic, you can receive college credit. So with that in mind, we hold you to the standard of the collegiate student. And so you're going to be writing some projects for us. We require that project papers be written APA formatting style with a cover sheet and a reference page. And if you've never done that, it's okay. There's a great resource that you can look up called Purdue OWL, and type in APA style in the Purdue OWL website, and it will explain the entire thing, as well as give you a template that you can download and just follow the template. It's a really important part of what we do. You should be a good writer because everything you write becomes an official legal document moving down the road. Next point is academic honesty. The fastest way to lose your position in the program is to turn in someone else's work. If you're plagiarizing, if you're downloading somebody else's papers and projects and turning them in as your own, you will be removed from the program immediately. It's the same as if you were cheating on a test sitting next to somebody. When you write a paper, it is okay to read other people's work, may even make notes off other people's work, but then you need to assemble that work in your own words, in your own information, blend it together, assimilate it in a form that is you. I don't need to read Dr. Red Duke's theory on trauma in your paper when we're talking about how to treat traumatic chest wounds. I just don't need to see that. It's pretty easy to find out if your work is yours or somebody else's. We have a system that we can run it through to check how closely your work relates to other papers that have been published that are online and places you can pick up those kind of papers. Your paper has to be Times New Roman 12-point double spaced, and we do hold you to that standard. If you turn a paper in that's less than the required word count or not double spaced, it's an immediate 10-point loss on the paper, and it doesn't take that too many times to catch up with you and affect your grade. So getting started, this presentation again is your first class. We're going to talk a little about history, and I'm sure that you know quite a bit of history so far. But we're going to hit it again. We're going to talk about certifications available in EMS for providers, as well as the roles of each of those EMS providers. EMS system, the team of healthcare professionals. Again, we are a team. If you were to go out into an ambulance by yourself, you're not a regular licensed ambulance. You're just you in a big vehicle. To be an ambulance, you need a partner. And that's only the first leg of the team. We actually are working in a position called pre-hospital care. And in pre-hospital care, we bring the injured and ill into a place where there's a guy called a physician or a lady called a physician who can continue what we have started. And to complete the circle, we're allowed to go into the field and pick these people up because a guy or a lady called physician allowed us to under their license. In every state, The EMS programs are governed under a medical director's license, a medical doctor, a physician. Some states actually have standardized protocols. The state of Texas has allowed each individual EMS organization to produce their own protocols and get approved by their medical director, which is great. That's a great thing about being in Texas, is we get to do those kind of things. Some states have their own published protocols for that state. And if you live in one of those states, then going from company to company, private or public, is pretty simple. Their protocols are all the same. In Texas, what an EMT or an EMT advanced may be able to do at the local private company, they may not be able to do at the next private company. And it may be the same for the EMS role in 911 versus rural and in town, where they have a lot of resources for paramedics, EMTs, and advanced EMTs. This course, we're going to talk about everything you need to become nationally registered. If you complete the course, get the right scoring, and our scoring base is a 75 on your final completion of everything all factored in, then you will be given a course completion, and you will be allowed to sit the National Registry exam. After passing the exam, the state of Texas, you file your paperwork that comes in from the National Registry with them, and then pay the fee. In a few days, they give you this really nice card that says Advanced EMT, and you're allowed to serve the public in that capacity. Most states have 4 training and licensure levels. The emergency medical responder, we used to call that the first responder. There's a lot of first responders, and someone like myself who's been in the industry for 30-some years, these are my favorite people. I hate going on a scene, especially rural 911, and having more than one patient and not have my first responders there. These guys and ladies save the day. I would encourage you, as an advanced practitioner of medicine in the field, to shake hands, pat backs, and thank them for what they do for us, because without them, we are unsuccessful. The EMT is the certification you now carry. The joke has been in EMS from day one that paramedics save people and EMTs save paramedics, and I believe that to be true. The advanced EMT, you're going to see that working with your EMT partner is the same for you. A lot of the stuff that you're going to be able to do, you won't be able to do as successfully if you're at odds with your EMT partner. And just like I tell the paramedics that you're a partner first and a certified person second, let's just talk about when you go onto a scene, the first level of safety is you. The second level of safety is your partner. So get that into your system now. Learn it, live it, love it, because your EMT is the backbone of what you do as an advanced provider. The advanced EMT is the first level of advanced provider. You're allowed to do some things that EMTs are not allowed to do, and you're crossing over into paramedicine, where you'll be invasive in your treatment of the patient. As an EMT, you were not invasive. In other words, you didn't do things that entered the body for the most part. And as an advanced EMT, you will be sticking needles in people. You'll be putting tubes down people's throats. You'll be doing more advanced assessments to determine what those patients need. And it's extremely important that you do it well. Patients' lives are on the line. You are considered an advanced provider in the field, and you're held to a standard, and I hope you hold yourself to a greater standard than what the state does. The next level we have is a paramedic. In Texas, we have certified and licensed. The certified paramedic can do a multitude of treatments for the patient, medications, invasive procedures. They are the highest level of certification in the field in the state of Texas and around the country. If you are willing to get a degree and pay a little bit extra money, you can become licensed as a paramedic. The training's no different outside of having a degree and having different CE requirements. They can do the same thing as a paramedic certified. I am a licensed paramedic. David Garcia is licensed paramedic. Our coordinator is not a licensed paramedic, and we work under her authority in this program. So it doesn't really matter what you're going to do for licensed versus certified. To my knowledge, there's no difference in pay. It just shows that you have taken the time or extended your education to include a degree. EMRs, from EMTs in a certain amount of things. Mostly the EMR, these are the non-professional folks. When I say non-professional, I mean these are the people who don't necessarily get paid. Not that they're not professional in what they do. They save us many, many days of the week, save our patients and us and what we do. But they usually don't get paid. In their training, there's not a clinical component in most cases. They have the classroom didactic portion where EMTs, they did the didactic in classroom and then had to put it into play in a real life role and be supervised by their peers to determine whether or not they had the skills to handle the certification. It's real important that EMRs understand and that you as an advanced provider take the time to train them as an obligation of what you do. EMTs, they can use the defibrillator just like the EMRs. They have the adjuncts, the airways, the OPAs, and the NPAs, those kind of things that they can use. And they have a couple medications that they can use, oxygen being the primary medication for all the certified personnel. In the advanced EMT, you've taken the step. Now you're an advanced provider. I said before, you're going to be invasive in what you do. The advanced life support provider, you can start IVs. That doesn't just mean sticking people with a needle. Any monkey can start an IV in an arm. And I mean monkey as in you could be very, very unintelligent, if that's really a word, and be able to stick a vein with a needle. The skill comes in determining why you're sticking a vein with a needle and what kind of fluid you're going to push into that person's vein, how you're going to push into the vein, and if you can do it safely. Just sticking a needle in an arm is not difficult. Understanding the whys and hows is what differentiates an advanced provider. There are medications that you're going to give. Some of them are also seen in the EMT level. You're going to give charcoal. If you're in a system that still uses activated charcoal. Breathing treatments, you're going to be a higher level of assessment in your patients, so you will be using albuterol and maybe some of your protocols may even introduce Atrovent into your system. Aspirin for your cardiac patients. Epinephrine, you'll be able to use the EpiPen, and in some states and scenarios, you'll be able to draw it up in a vial. Nitroglycerin, tablet or spray. If you remember, as your EMT, you had to use the patients and you had to assist them. In many situations, you'll be able to determine if that's appropriate for your patient and move forward as you would if a paramedic was standing right there with you. Oral glucose for your diabetic patients, oxygen, and in some scenarios, you'll be able to give Tylenol in some of the pediatric settings and some of the advanced areas where a fever may be an issue that you're dealing with. Paramedics have extensive ALS training. That's what I hope each of you do. I hope you see this ALS certification that you're undertaking now as a stair step into your advanced levels of paramedicine and beyond. I hope some of you go on to become nurses and physicians in the hospital chain of survival that we deal with daily, because it's important. Paramedics don't do a lot more than what ALS providers do, the AEMT. We do have some cardiac differences that we handle. We're more hands-on with the cardiac, and we have quite a bit more drugs. But in all truth, most of the drugs that we use are repetitious in nature, and after a short period of time, you can become pretty adequate at handling the drugs because you'll see the situations so often repeated daily in some situations. The EMT course includes 4 levels of activities, and I talked about it before. You're going to have lectures. There will be discussions. We will ask questions, even in the online platform. We will be asking you questions in the question section that you can see where the chat box areas. The instructor may ask a question as he's teaching, or if I'm teaching on cervical vertebrae, for example. I'm just throwing this out here, and I say there's 7 cervical vertebrae, and that the 4th cervical vertebrae is called the forward cervical vertebrae. That's just made that up. And I may ask the question, as I continue teaching, I identified the 4th cervical vertebrae as the forward cervical vertebrae. Is that accurate? There's a couple reasons I'm doing that. Number one, I'm making sure that you're still plugged in and being active in the class. So the other thing is, I want you to hold me to a standard. And if there's something that I made a mistake on or messed up on, we want to revisit that. And don't have all the answers, but I will find the truth for you as much as I can. There will be demonstrations. Some of the things that you're going to do in the online as well as the in-class portion is demonstrating skills. And we have special ways that you can do that. And the class presentations and scenarios are very important. Training. EMTs are the backbones of the EMS system, and by EMTs, we're talking all EMS and first-level advanced care providers. You provide care to the sick and injured, and that doesn't just stop when the hospital transport ends. You're going to be seen as an advanced care provider, so you will be expected to be a teacher as well. And there's going to be another slide that's going to talk about that in more detail. Some of your situations will be life-threatening situations that require a real test of your skills, which is why we require you to do so much every year to stay sharp. And then other ones may simply be supportive care. You may just be called out at the 2 o'clock in the morning. I haven't felt good for 20 days, and I need to talk to somebody, and maybe go to the hospital, maybe even not go to the hospital. In your training, again, kind of refreshing on what you already have learned as an EMT. Scene size up, we will do that extensively, but you should have already done it. This determining how many patients you have, whether the situation is what we like to call a load and go, or if you need additional resources. The assessment of your patient, what are you looking at? I mean, what is the patient going on? How are they being taken care of? And then the next step, the third bullet here, is where the differentiation really happens. Your treatment before may have been, let's put oxygen on this patient with shock. Let's cover him with something to keep him warm. And since there's no ALS available, let's get him to the hospital as fast as we can. What may be changing now for you is, you're going to put your patient on oxygen. You're going to cover them to keep them warm. But you may also determine that invasive intravenous fluid boluses and fluid challenges may improve the situation and the patient's chances of survival. And that's where you would come in as the advanced level provider and initiate those in the field and increase the patient's ability to recover from their injuries or illness. Packaging is no different in what we do. You just may have a line hanging off of somebody. And then your EMS career, you're going to see a little bit of a bump in most cases in your pay, and your availability to get jobs will be a little bit easier based on what you can do for your patients in the field. Excuse me. The licensure is no different that you did for your EMT. You have to have a high school diploma, a GED, or in Texas, if you had homeschooling, you have to have a certificate of completion to show that it would be equivalent if you sat through a public school program. Proof of your immunizations must be current, and you must have a valid driver's license. I don't imagine that this is anything new to you, but to be on an ambulance, you have to be BLS certified. You have to have your current CPR cards. You have to have been through an approved EMT course, a state written certification exam. We don't do that in Texas, but we do have a national registry exam that you will take, and then a state recognized practical examination. Once again, we don't have a state practical examination in Texas. You do a national registry exam, and then we accept the national registry to issue you a state license based on what you did in your national registry program. In your national registry program, when you do your practical examinations, you'll have to demonstrate that you have the mental and physical ability to complete the job. There are a lot of people that I've had as students that come in, and the first time we went and did the rotation at the cadaver lab, they realized right then that this may not be the job for them. And that's something you'll have to consider for yourself. If you're already an EMT, I'm sure that you've been exposed to enough now to know whether or not you're in the right profession. And you have to stay compliant with how the state sees that your license should be handled. You're held to a different standard. Can you imagine being picked up in an ambulance and recognizing somebody that picked you up as being somebody on the TV that got arrested for 3 or 4 DWIs? That's just not what we expect. So local and state provisions are there, and you are held to that standard. Most of this that we do has been guaranteed and brought in from the Americans with Disabilities Act, the ADA. So if you have physical disabilities, doesn't mean you're prohibited from being a medical provider. You still have the ability to be disabled and have a license. In fact, on more than one occasions, I have worked with those who had disabilities. I was blessed in Houston, Texas, to work with a gentleman that had suffered from cerebral palsy as a young man and had some disabilities that affected his ability to ambulate very fast. But one of the smartest guys I knew, and in certain situations, the only guy I wanted in the back of the truck with me. So it's real important that we treat everybody with the respect and professionalism granted by our certifications. An overview of what EMS is. With most of my classes, you're going to have a little video that goes into the class. So at this point, the next slide is going to talk to us about the video. I encourage you to take notes, as with any class that we have. All the information is subject to testing and quizzes. So please, at this time, be ready to take notes, because the little video is going to start next. And some of you may or may not have the exposure of where EMS came from, but it's really kind of a neat story, and I hope you enjoy it.
Here. Okay, well, how it all began. You know, in the 1790s, during the Napoleonic Wars, Jean-Luc Leray, Napoleon's battlefield surgeon, developed these flying ambulances, is what they called them. They essentially were horse-drawn wooden boxes where they could slide some people on stretchers into the back and take them from the battlefield to the hospital, as it was. Not much changed during the Civil War. Soldiers were put on flat wagons and horse-drawn and taken back to Army surgical hospitals, where if they survived their wound, they often died from mass infection. Because prior to these times, penicillin hadn't been developed yet, and so infection was a major cause of mortality in injured soldiers. World War I saw the Volunteer Ambulance Corps and the advent of the automobile. The Korean and Vietnam Wars, that's where we started to see MASH-type units or cracker boxes. Also, helicopters were incorporated to get people from the battlefield back to the hospital. And it wasn't until the 1900s, actually mid-1900s, that non-military ambulance services started popping up in the United States. They were operated by hospitals and fire departments, primarily in Iowa. They were operated by funeral homes. And there still are a couple ambulance services in Iowa that are owned and operated by funeral homes. The early ambulance industry, there were no requirements or standards for equipment. There were no requirements or standards for training or the design of an ambulance. So if I felt like I wanted to be an ambulance company, I could take my station wagon and pop a red light on the top of it and a magnetic sign on the door that said Jeff's Ambulance, and off I'd go. There was no requirement for me to even be in back with the patient. And that's where funeral homes became primary operators of ambulance services. They would place the patient in the back of the hearse, and if the patient was dead, they would take them to the hospital if they were alive, and then take them to the funeral home if they were dead. In 1966 was the publication of the White Papers, and the White Papers talked about death and disability on American highways. And the Department of Transportation, the DOT, was charged with developing EMS standards and an EMS system, because essentially the White Paper, when published, indicated that people are dying on the highways because there's nobody trained to take care of them after a motor vehicle collision. It was in the 1970s where the founding of the National Registry of EMTs occurred. The National Registry of EMTs, not to be confused with the National Association of EMTs, was a body designed to look at certifying providers at different EMS levels. And many, if not most, I think all 48 states use the National Registry as a accrediting body to certify their providers within their state. It was the National Registry of EMTs that adopted the EMT oath and the EMT Code of Ethics as well. In 1973, the National Emergency Medical Services System Act, passed by Congress, flooded the rural areas of the United States with money to help develop EMS systems. And NHTSA, the National Highway Traffic Safety Association, was also instrumental in developing standards for EMS systems. NHTSA, a arm or a break-off of the Department of Transportation, we're familiar with them in publishing safety crash data and those sort of things, but when it comes to EMS systems, the National Highway Traffic Safety Agency, or NHTSA, is a very important organization, as they're responsible for developing the components of an EMS system, as well as multiple publications throughout the last couple decades that talked about where EMS is at this point in time and what needs to occur in order for it to survive. The different parts of the EMS system, according to NHTSA, one was regulation and policy, and that was the national government saying that each state needs to establish laws, policies, regulations concerning EMS within their state. And our Bureau of Emergency Trauma Services, or BETS, a subdivision of the Iowa Department of Public Health, is responsible for doing that. NHTSA also talked about resource management, and that was a centralized coordination of emergency treatment and transport resources. And that's something that we struggle with. Resource management does every county need multiple transporting ambulance services? And there are some counties in Iowa that may have up to 8 different transport services. And is that really good resource management? And I think those are things that continue to be discussed at a national level. Human resources and training were an important piece of this as well, because there were no standards early in EMS, and now NHTSA and other groups have established training requirements for the different levels of EMS providers and minimum standards for certification. Transportation dealt with the safe and reliable transportation of the sick and injured, which led to the development of ambulance manufacturer criteria, so that if a company wanted to make ambulances, they had to meet certain criteria and safety factors when making those ambulances. Facilities were part of the EMS system. The EMS services can pick these patients up, but where are they going to transport them? And we're really looking at time-critical conditions now when it comes to transportation. Things like heart attacks, strokes, and major trauma all are time-critical and are either being transported to the closest facility or the closest appropriate facility, whether it be a facility that does balloon angioplasty and catheterization of heart attack patients, or whether it be a major trauma center. Communication was to establish a universal access number, 911, and they were to dispatch ambulances. They were to dispatch ambulances to the scene, ambulance to the hospital, and also communication is important, that we have redundant communication, more than one form of communication, so that we can not only talk with ambulances and hospitals, but all our other partners that respond with this, to include law enforcement, fire, emergency management, Public information and education was part of the system development for system standards, and that required us as EMS providers to educate the public about the role of EMS, how to access EMS, and how we as EMS providers could be active and participate in injury prevention programs, because some things we cannot fix. Only prevention can fix them. And those are, let's say, for example, trauma. We know that the vast majority of all life-threatening trauma, if not trauma that causes death, is preventable. And that prevention relies on our ability to develop injury prevention programs. So that was a big, important part of EMS system development. Medical direction, we have to have oversight, some medical director who is accountable for EMS people within their system. So as an EMS provider, we can practice EMS within our scope of practice, which we'll talk about later, as long as we are overseen or directed or guided by a medical director within our community. Trauma systems, Iowa developed its trauma system back in 2001, where we looked at ways that we could triage trauma patients, and based on our triage determine the most appropriate facility for them to be transported to. We have in place the out-of-hospital trauma triage destination decision protocol that you'll become familiar with within this course. And then evaluation, establishing a program for evaluating and improving effectiveness, which some would call quality management, total quality management, quality assurance, quality improvement. And it's just based on a concept that we all know that when we go out and take care of patients, that we do it to the best of our ability, but we also know there's room for improvement. And by monitoring our care, we can identify opportunities that allow us to improve. So components of an EMS system include emergency medical dispatchers. Now, some counties have 911, E911, emergency medical dispatchers, or EMDs, I should say, is what they're called. And some got them and then didn't renew because of the cost associated with them. And there are some that have never been trained at that particular level. An emergency medical dispatcher has a set of cards in front of them. When they get a call from a caller, they can ask certain questions, which leads them through an algorithm within the cards, and they end up with a scripted message that they can give the caller. It also includes EMS responders at all levels, whether it be an EMR, an EMT, an advanced EMT, or a paramedic. And then it includes the emergency department and the hospital. And within the hospital, doctors, nurses, and other allied health personnel like lab and radiology and mid-levels. And then specialty centers, whether they be burn units or major trauma centers or major stroke centers, those sort of things. And that's what they're talking about here. It takes all of us in the system. We have an inclusive EMS system within the state of Iowa involving everyone from the emergency responder all the way to the rehab person once the patient is discharged from the hospital. So it's important to know what medical services are available within our community and how important it is that EMS personnel know the capabilities of your community medical facilities. Because as an example, we know that when we're talking about stroke patients and their need for a head CT, if we think they're having a stroke and our local facility, their CT scanner is down and they're putting in a brand new one, well, it doesn't make sense if we have a stroke patient to take them to a facility that doesn't have a CT scanner. So knowing those capabilities is important. And, of course, the consequences of transporting a patient to a facility not equipped to handle the problem is a delay in getting the patient the care that they need, which the delay could be costly. So assessing the EMS system begins with the patient or the caller, because sometimes the patient doesn't make the call. The call goes into a comm center where an emergency medical dispatcher dispatches emergency medical responders, whether they be fire, first responders, EMTs, advanced EMTs, and paramedics, who then package and transport the patient to the emergency department, where in the emergency department they're cared for by not only doctors and nurses but other allied health staff. So gaining access to the EMS system requires a universal number, and of course we know ours is 911. Some of it is enhanced, where they can triangulate where the call is coming from, so they'll know the location. Emergency medical dispatchers, as we mentioned, can provide instructions, and those instructions may be some life-saving information to get the caller to provide some care prior to the ambulance getting there. Critical decision making is a very important concept in EMS, and it's very difficult to learn. Critical thinking is something that you develop as you become more familiar with things like pattern recognition. You become more familiar with different disease processes and the stages of the disease and how that affects the body, as you become more familiar with anatomy and physiology. So critical decision making is very difficult to teach. It's something that you learn based on experience. And we know that the decisions that you make as an EMT often can be very time critical. Whether we stay with the patient and provide care on scene, or we move quickly and transport the patient to a facility where they can receive further care. So some examples of critical decisions: is it better to take the patient to the closest hospital or to one further away, but is more appropriate for the condition? So let's say I'm in La Mars, for example, and La Mars is 28 miles from Sioux City, and I'm down there on Highway 75 between La Mars and Merrill, and I'm working a major motor vehicle collision, and my patient has a serious life threat from their traumatic injury. Does it make sense to go back to La Mars, or does it make sense to go another 20 miles in the opposite direction to a level 1 or level 2 trauma care facility? Is the patient stable enough for further evaluation on scene, or should the patient be transported immediately? We're going to have to make those decisions as to whether or not we believe we have time to stay with the patient and get a good history and good discussion and do the things that we're taught to do, or whether we just provide life-saving treatment like administer oxygen, assist ventilations, cover holes in the chest, and then transport them immediately. And then we're going to learn to do different treatments and provide different care. And it's just important to know at what time do we provide the care, because we'll have patients that we're very, very busy with because of the seriousness of their injuries or their medical condition, and we may not get through everything that we think that we should because of the need to move the patient quickly to a hospital. There are different levels of EMS training that's out there for you. You got the emergency medical responder, and that was previously called the first responder. First responder is a term the federal government took over when after 9/11 to mean the first person who comes in contact with the patient, which could be the lay rescuer. So they're now called emergency medical responders. And then you're taking the emergency medical technician course, and they were previously called EMT basics. And then the advanced EMT was previously called the EMT intermediate, and then the paramedic was previously called the paramedic or paramedic specialist. Some roles and responsibilities that you have as an EMT, first and foremost, is your personal safety. You're going to find yourself in situations that are hostile, situations that are dangerous, and we all want everybody to go home at night, so it's just really important that you focus on scene safety. Then safety of the crew, safety of the patients, and lastly, safety of the bystanders. You're responsible for doing a patient assessment. 80% of the diagnosis, or 80% of figuring out what's wrong with your patient, you're going to acquire by doing doing a good patient assessment and obtaining a good history, and we'll talk about that. You will provide patient care, some on scene, some in the ambulance, and some in hospitals as well. It's going to require a lot of lifting and moving, so we will cover lifting and moving and the importance of doing that properly. You'll be transporting patients from the scene to the hospital, from hospital to hospital, from nursing home to hospital, those sort of things. And then once you deliver the patient to the receiving facility, you're going to have to transfer that care to somebody of equal or more training. And I think one of the important things that we should keep in mind about being an EMT is our role as a patient advocate. Many times the nurses and the doctors don't see the home. They don't see the scene. They're not familiar with the patient. So it's important for you to be an advocate to make sure that the patient information is transferred properly so that you paint a good picture of the situation that the patient's in. So how would it impact an older adult patient if they were transported to the hospital without glasses, hearing aids, or dentures? Those are things that they rely on to see and to hear and to eat. So obviously if they couldn't see, if they couldn't hear well, if they had trouble eating, that could be problematic for the patient. So it's important that, if you are caring for a patient and they're able to talk to you, especially if you notice they don't have their teeth in, or you notice they're having a hard time hearing you, asking them about, do they have hearing aids, do they have teeth, where are they, and then get those things for them. On a routine call, would taking the time to gather these items have a negative effect on the patient care? And the answer is no, not on a routine call. Again, there's only 3 real time critical situations that we deal with. One is a stroke, one is a heart attack, and the other is a life-threatening traumatic injury. So how about assuring the home is secure and locked before leaving? And that's one of the things that, you'll do as an EMT as just a courtesy. If the patient lives alone and you've got them strapped to a stretcher and you're taking them out the door, they may find it more comfortable if they know that you're going to lock the door and put their keys in their purse and that they hold on to their purse and, that sort of thing. Could the concept of patient advocacy also extend to the community? And the answer is yes. The number one cause of death in the elderly is falls. So a fall prevention program for the elderly is something that an EMS provider could spearhead within their community, as well as poisoning awareness, pool and water safety programs for children. All those things are patient advocate and prevention programs that as an EMT you could be involved in. Now, you can imagine that as an EMT, there certainly are some physical attributes or traits that you're going to need, and one of them is the ability to lift and carry patients up to 125 pounds. The cot itself weighs about 70 pounds anymore with the power cots and their battery and that sort of stuff. And then you've got the patient on there and you've got equipment on there. But collectively, if you and your partners, are able to each lift 125 pounds, you should be able to carry most patients. You need to have good eyesight for distance and reading because you're going to be looking at small labels and those sort of things. You should be aware whether or not you're colorblind because that may affect your ability to interpret some of the stuff that you assess as an EMT. You need to have good communication skills, both oral and written skills, because you're going to have to give verbal reports about your patient's condition to the receiving facility, as well as write a patient care report. You need to be pleasant. I know that getting called out at 3 o'clock in the morning in the rain is just not a very pleasant thing to do or deal with, but that's what we sign up for. We don't pick our patients. We can't choose the conditions that we respond in. They chose us, and it's important that when we do respond, that we are pleasant, that we're sincere, that we are resourceful, because you'll learn to do things, but in reality, situations may dictate that, there's just not enough room to get a longboard in here to get the patient on. So how am I going to move the patient without a longboard? Well, you need to be a self-starter, and I think that's one thing that's very common in all successful people in EMS, the ability to, to take the bull by the horns and problem solve. You need to be emotionally stable to start with. There are many people who are in EMS for any length of time do develop post-traumatic stress disorder, and that's because of the type of calls that we respond to. Some of them are horrific in nature, and some of them end a person's career before it really even gets started. You need to be able to lead, take control. You need to be neat, clean, have good moral character, and respectful of others. Now, we'll talk about ethics being a community belief system, and moral is, something that you own, that you believe in or belongs to you. So good moral character is important because there's no room for bias in EMS, and we all have biases, and it's very hard not to allow our biases to cloud some of the care that we provide, and we wouldn't think so, but all the research says that we do. You want to be in control of your personal habits. You want to be able to have control in conversation and be able to communicate properly. And just as, important as communicating properly, you're going to need to be able to listen to others as well. You're going to need to be a good listener so that you can understand what the patient is trying to tell you. And it's important that we approach patient care with empathy. We also approach patient care non-judgmental and fair, treating all patients as we would want our family members to be treated. We need to keep our skills up to date. Skill deterioration is common in EMS. Not that we have a lot of technical skills, but if they're high-risk, low-frequency skills that we don't perform very often, we really need to stay up to date on those. We need to take refresher courses when our certifications are due, when our CPR is due, when any of the other courses you take are due, like PHTLS or AMLS. You need to go to continuing education courses, conferences, seminars, lectures. As an EMT, you're going to be required to have a certain number of continuing education hours in order to renew your EMT when the time comes. So where will you become a provider? As an EMT, you could work for an ambulance service. You could work in a fire department. You could be fire/EMS. Rural and wilderness teams need EMTs. Urban and industrial settings need EMTs. And, of course, volunteering with your local search and rescue, fire rescue, those sort of organizations. Now, the National Registry of EMTs, they handle all the registration for EMRs, EMTs, advanced EMTs, and paramedics who successfully complete the National Registry exams. So at the end of your course, you're going to take both a written exam and a practical exam that has been validated, and should you pass, not should, you will, when you pass the exam, you'll get that certification. And by passing National Registry, again, 48 states acknowledge that as a competency, and allows you to move from state to state without having to take their state tests or having to reapply for a state license. So it does help you with reciprocity, and it does help you when applying for employment. Now, quality improvement, here we're talking about continuous quality improvement, and it really works best if we approach continuous quality improvement with a self-review or a self-evaluation. You'll find out in EMS that everybody's a critic, and we are our worst critics, but we need to do a self-reflection of our care following each call to identify things that perhaps we could have done better, and by doing that, without beating ourselves up too much, we certainly can make changes and improve the way in which we provide care. Now, everyone in an organization has a role in continuous quality improvement, from the person preparing the written documentation to those who are actually involved in auditing the run reports, for those who obtain feedback from patients and hospital staff through evaluations. Quality improvement also includes maintaining your equipment, making sure that when you go out on a call and you need oxygen, the tank isn't empty, or when you need a specific piece of equipment, it's not all used up. Quality improvement also includes maintaining your education, completing your continuing education. All patient care is performed under the direction of a medical director, and we briefly talked about this already. The medical director has the ultimate responsibility for patient care because you're working under their license. Should you have a major error in the way that you provide care, that could affect the medical director's license as well. Medical directors are to oversee your training. They're to help develop your treatment protocols. They're to allow you with information to provide offline medical direction like standing orders or state protocols. And they're also available should you call them and need some online medical direction. Your role in public health is, certainly you're in the home of these patients, whether they be very young or very old, and you can, look at their environment. Knowing that falls is the number one cause of death in geriatric patients, if they've got a lot of loose rugs that they could easily trip or slip on, then letting public health know that, or letting some family member know that perhaps you could get some double-sided tape and tape those down. And then injury prevention programs for the youth, which include bicycle rodeos where you're issuing helmets and teaching them safe bicycle habits. And then participating in public vaccination programs, certainly keeping up your immunizations, and then disease surveillance. Should you notice an influx of the number of patients that you're picking up with the same symptoms over a week's period of time, could indicate the influenza is present. Research is very sparse in EMS. The whole purpose of research is to focus on improving patient outcomes through evidence-based techniques. We're really looking at something called evidence-based medicine. Not only in EMS, but all levels of healthcare are basing what they do on evidence that shows what they do improves outcomes. And when developing evidence-based medicine, the process is to first form a hypothesis. And hypothesis is a belief. There's no proof to it, but the hypothesis is, let's say, for example, cervical collars immobilize the spine. You would think that if you put a rigid collar around somebody's neck, that it immobilizes their neck. And then you review literature and look at the available evidence that would either prove or disprove your hypotheses, and you evaluate that evidence for its level of robustness. Things like a random chart review is not a very effective method of doing research, where if you have a set of training and protocols and stuff beforehand, and then you apply those, and then you go back and look at the outcomes that the patient had. That's a much better research practice. And then, if the evidence supports your hypotheses, you should adopt it. If it doesn't, then you should move on and look at a new one. Not all research is created equal. Some is animal research, some is human research, some is randomized trial, blind, double placebo, all kinds of different things that are out there as far as the method of how they do medical research. And so you need to rely on the scientific method that is going to produce the most accurate result for what you're looking at. Exacting and comprehensive studies are both difficult and very time-consuming, and the problem with time is, we don't spend a lot of time with the patient in the field. We have them for such a short period of time. It is difficult to determine if what we do really makes a difference on the back end when they're discharged from the hospital. We do know things like early CPR, early defibrillation, those sort of things do make a difference. And then once we evaluate the research and extract the data, we can develop an objective opinion. And we'll talk about objective and subjective information when we look at documentation. So we all have biases, and biases cloud the way in which we see things. So some methods of reducing bias is to do a prospective study. Prospective is to do it to do the study live. Retrospective is to go back and look at charts. Randomization reduces bias. If I randomize the sampling that I take, in other words, on even days, we're going to do this. On odd days, we're going to do that. Then I really don't have any control over what type of patient gets it, just on the day. Control groups, again, you can identify ahead of time in your study who the control group is and apply this hypothesis only to that group. And then look at other similarities in other groups from other studies to see if your research or your data is this comes to the same conclusion that they do. Some types of medical research could be done on case studies and patient care reports. They can be cohort with other organizations or other people. They can be case-controlled studies where you only look at certain things. They can be randomized controlled trials, which by far are the most robust type of research out there. They could be systematic review, and meta-analysis is another method of looking at data and analyzing it. So one question to ask when you're thinking about evaluating a study is, identify the biases and the flaws in the methodology right away. You see this, and a good example would be, let's say that I got this new drug and I want to do some research to prove that this new drug is the cat's meow. Well, obviously, if I make the drug and I'm doing the research, there's a bias there. And then what sort of methodology did I use? Again, remember, retrospective is the least robust method of getting data. Questions to ask before participating in a study is, what do I need to do in the study, and what sort of information do I need to know before starting the study? You want to give it a name. You want to know who the investigator or the primary contact for the study is. You want to look at what the question or the hypothesis is that they're trying to prove, and what sort of people were included in the study as well as those that were excluded. What sort of conditions were included in the study as well as those that were excluded. What data do I need to collect? We're good in EMS about collecting lots and lots of data, but then what we do with it once it's done is something that we struggle with. Whenever you conduct a study on live people, you've got to have their consent. So how are you going to obtain that consent before enrolling them in the study group? If treatment is going to be randomized, how are you going to randomize that treatment? Are you going to in some randomized controlled trials, they have an envelope in the back of the ambulance, and on a specific day, if this patient meets the criteria to be in the study group, then you could open the envelope and see how they're going to be treated. So that's randomized as well. And then what sort of samples will need to be collected, and what sort of potential benefits is the patient going to achieve as a result of your study results. The risk to the patient as well. Has the study been reviewed and approved by a board? Does your medical director approve of the study? Does your EMS agency approve of the study? All those things need to be included when conducting research. So that's sort of a brief look at